Good evening. My name is Shabnam Sood and I'm presenting a poster, Psychiatric Inpatient Discharge Practices, Impact on Aftercare for Patients on an ACT or Assertive Community Treatment Team. Standards of care for discharge planning include scheduling an outpatient appointment, communications between the inpatient and outpatient providers, and forwarding a discharge summary. It has been seen that patients who had all three elements kept their first appointment and had a greater likelihood of follow-up than individuals who had none. Post-hospitalization outpatient appointment is scheduled in 41 to 79.8% of patients discharged from psychiatric hospitals. There is a high rate of patients not attending aftercare appointments within 30 days of discharge, and it ranges from 25 to 65%. Risks of non-attendance is higher for patients who were hospitalized involuntarily, had no prior public psychiatric hospitalization, or prior outpatient mental health visits and longer lengths of stay. The lack of attendance at post-hospital discharge appointment has been shown to be associated with increased risk of relapse, rehospitalization, homelessness, decreased quality of life, suicide, and involvement with the criminal justice system. Communication between the inpatient and outpatient providers has been shown to increase attendance of post-hospital appointments, while incomplete or unclear communications can lead to breakdown and transitions of care. The hospital discharge summary is the main conduit in transferring care from the inpatient hospitals to the outpatient team. A complete summary includes diagnosis list, treatment provided, rationale for medication changes, and medication list with changes. Discharge summaries are available to primary care physicians at the first hospital visit only in 12 to 34% of the cases and were often incomplete and lacking important information about medications and test results. Only 25% of the discharge summaries had all the elements complete. Direct access to inpatient data was the strongest predictor of the availability of discharge summaries. There is an increased use of utilizing electronic medical records for transfer of health information, but the rates of use lags among psychiatric units when compared to the acute care hospitals. The Assertive Community Treatment Team, or the ACT team, serves seriously mentally ill individuals who struggle to maintain in the community when discharged from highly structured and supervised inpatient settings. The teams take on patients who tend to be high utilizers of both inpatient and emergency services, with the goal of reducing hospitalizations and more adequately meeting their needs in the community. When ACT patients require hospitalization, the ACT team attempts at least weekly coordination with the inpatient team and 3 times weekly contact with the patient. The ACT team psychiatrist collaborates with the inpatient psychiatrist with the minimum goal of upon admission and discharged, the patient is scheduled for an outpatient psychiatric visit to take place within 72 hours of discharge. Because of the complexity of these patients, they are often on numerous medications, including long-acting injectable medications, making the timing and quality of communications essential for smooth transition to the outpatient setting. Missing or incomplete discharge summaries hampers the care for these patients and leads to an increased risk of relapse or readmission. Our aim was to explore if providing these high-risk patients greater discharge planning practices of having a post-hospital appointment scheduled and a contact made by the case manager to bridge the gap between inpatient and outpatient care will lower the risk of rehospitalization and increase rates of attendance at the post-hospital appointment. The records are reviewed for reasons for missing the appointment, and the discharge summaries were reviewed for the availability and completion of all elements. Material and methods. The study is a retrospective chart review of patients on the ACT team who were hospitalized on or after May 15, 2021. 50 consecutive ACT team patient admissions were included in the study. The list of admission was obtained from the ACT team, which keeps a daily log of all patients who were hospitalized, the day of discharge, and follow-up appointment schedule. Data included age, sex, diagnosis including primary psychiatric diagnosis, medical diagnosis, and the substance use diagnosis, length of stay, and the reasons for admission, be it psychiatric or medical cause. The charts were reviewed for communication with the outpatient provider on discharge, if a discharge summary was reviewed, contact made by the case manager post-discharge and before appointment dates, and if the appointment was kept, and any rehospitalization within 30 days, and the reasons for a missed appointment. The discharge summary was reviewed for an updated problem list, rationale for medication changes, if the medication list was available, and if available, whether it was complete or not, and included the doses of the long-acting injectables, if applicable. Statistical analysis included chi-square test, and summary statistics were described as counts or percentages. Results: the demographics. Most of the patients were males as compared to female patients who were only 20% of the cases. The mean age was 40.9 years and ranged from 19 years to 63 years. Vast majority of the patients were admitted for psychiatric causes as compared to those admitted for medical causes. The length of stay varied from a minimum of 1 day to a maximum of 27 days with a mean stay of 10.9 days. 18 or 36% of the patients were readmitted. The common diagnosis was schizoaffective disorder followed by schizophrenia, bipolar disorder, borderline personality disorder, and unspecified depression. Substance use disorders included primarily methamphetamine use disorders in 48% of the cases, followed by alcohol use disorders, cannabis use disorders, and opiate use disorders. All the patients, 100% of them, had appointments scheduled within 72 hours of discharge. A case manager contact was made in most of the cases, 88% of the cases. However, only 30 or 60% of the patients kept the first appointments. The reason for missing the appointments was substance use followed by homelessness. The rates of communication between the inpatient and outpatient provider was very low, and a contact was made in only 10 cases or 20% of the cases. Factors affecting readmission rates. There was little difference in the rate of readmissions between those who kept appointments post-hospital and those who did not keep the appointments, 36.7% versus 35%. Similarly, no difference existed between patients for a doctor-to-doctor completed at discharge for those who were readmitted compared to those who were not readmitted. Primary use disorders did not signify very differently. Similarly, it did not matter if the patients had a problem list, rationale for medication changes, or if the medication list was received or case manager contact made among the readmission rates. The discharge summary was received via fax, print, or electronic medical records in 33 or 66% of the cases. These were reviewed for the elements considered essential for continuity of the care. The problem list was available in 29 or 58% of the cases. Medication list was received available in only 33 or 66% of the cases, but the rationale for medication changes was documented only in 6 or 12% of the cases. The long-acting day and dose was applicable only in 60% of the cases and available only 50% of them. Discussion. Breaks in continuity of care when transitioning from inpatient to an outpatient setting lead to increased risk of relapse and hospitalizations. It has been postulated that having a post-hospital appointment schedule increases the odds of patients attending their appointment. Despite having an appointment scheduled for every one of our patients and a case manager contact made during the transition period after discharge and prior to the first appointment, the attendance rate for 4 hospital appointments was only 60%. This was higher than the average but lower than what was expected. The reasons for missing appointments were primarily substance use followed by homelessness. Factors that have been postulated to decrease rehospitalization, such as the communication between the inpatient and outpatient providers, having an accurate and timely medication list, discharge summaries did not differ in the patients who were rehospitalized when compared to those who were not. Discharge summaries were available when available, were often incomplete with only a handful documenting rationale for medication changes or hospital course, and little over a half had a complete medication list. Conclusion. ACT teams are designed to improve system factors to keep patients out of the hospitals. It includes frequent contacts with case managers, post-hospitalization appointments made, greater communication and coordination of care between the inpatient and outpatient teams. In this study, it appears that the patient factors rather than system factors were the cause of patients missing appointments, primarily substance use and homelessness. While ACT teams provide substance use services such as groups, counseling, providing additional supports or bridging strategies during the transition period may improve appointment attendance rates. For rehospitalizations, the findings were very surprising, and factors that we postulated would increase the rehospitalization rate, for example, not having an accurate medication list, missing long-acting injectable dates or incorrect doses, or not having any idea for rationale of medication changes, did not achieve statistical significance. It could be possible that this is a population which is inherently at a higher risk for multiple hospitalizations. Investigating the patient-specific factors that lead to rehospitalization is needed and can be potential targets for additional services. Discharge summaries are missing crucial information. Policy changes would be needed to address these issues. Thank you.